as you know, I'm a medical doctor. I've been at this for, well, I graduated in 1972, so 42 years. I love being a doctor. I love taking care of patients. This is the most fun thing for me to do. Every session when we run a 10-day program, I still have the opportunity to take care of between 50 and 60 people all by myself. I get to be their doctor. And I dread the day when I can no longer do that myself. It's fun. That's what keeps it really interesting for me, is to meet new patients and meet new audiences and interact and try and figure out different ways that I can convey the message so that you can enjoy a healthier life. But it's not just my patient care and my practice that I put effort in to try and share this message. I've done other things. I've written some national best-selling books, which has worked out well. I have tried to teach some courses. I lecture around. And out of frustration, a couple of years ago, what I thought would be a good thing to do would be to get some legislation going. To maybe see if we could make it a law that people should be healthy and doctors should teach health care. And maybe we should even have a law so bold and blunt as to require physicians to know what human beings eat. I thought that was a pretty good idea. Of course, I've been thinking about it more than 2 years. So I went to the California legislature body, to Senator Rodney Wright's office, and I asked whether or not we could do a law, a bill, a Senate bill, that would require physicians to learn what human beings eat. Of course, not very many people have thought that was important, but I thought it was important. So in early 2011, we sat down and wrote this bill. I was the primary author of the bill. And in April, I had a chance to go to the Senate, to a committee, to talk to them about how important I thought it was that we have doctors know about human nutrition. And because they don't know anything about human nutrition, a law seemed appropriate. And we sat down and talked about it in this committee meeting. Don Forrester, Dr. Don Forrester was here. He was there. And he and I and the senators talked about it. And when I walked in, they said to me, "Don't bother. We're not going to pass another law that requires physicians to do things." And I said, "Okay, I'd like to give you some reasons why I think we should have a law that doctors should know about human nutrition." And so what I'm going to talk to you about for the next few minutes is this process that started in early 2011 and how we got a law passed called SB 380 that should, by all rights, force physicians to learn what human beings eat. This started a long time ago, this idea that we ought to know what human beings eat. I was one of the early doctors that thought that was a good idea. And finally culminated in SB 380, which is the bill that you can find if you go to the internet. You just type in California SB 380, and this particular legislation comes up here. All this started when my eyes were opened, and I know I'm going to do that for some of you this weekend. A lot of you have heard this message before, but some of you this is all new to. Your eyes need to be opened to the idea that there is a proper diet for people. There really is. I mean, there's a diet that allows people to look, feel, and function their best. I never learned that in medical school. I really didn't learn it or even get any clue to it until I was a senior medical student when this gentleman, a doctor, Dr. Dennis Burkett, came to my medical school when I was a senior in Grand Rapids, Michigan at Michigan State University. And he came to my medical school in a noontime conference and he told me that food was important. First time I ever heard it mentioned. He said that what people ate was important. And the reason he knew this is he was a surgeon who trained in Edinburgh, Scotland, and after his training as a surgeon, he got a job in Africa, in Uganda. And quickly he was promoted to be the head of Ministries of Health, where he served for 17 years taking care of 10 million people in Uganda, Africa. And what this man told me, which opened my eyes for the first time, is he told me that he did not see any obesity in Uganda, Africa. 10 million people, 17 years. He saw one case of heart disease, and that was in a judge that trained in London and came back to Uganda and had a heart attack. He saw one gallstone in 17 years. He saw no deep vein thrombosis. He saw no pulmonary embolus. He saw no type 2 diabetes. He saw no colon cancer, no hemorrhoids in 17 years. And what he told me that the reason is because of people's diets. And what he focused on was fiber. Well, fiber is only present in plants. What he was trying to tell me was that the reason these people in Uganda were healthy is because they lived on plants. starches like corn and potatoes and beans and vegetables and fruits, and ate very little meat and virtually no dairy. That's what he's trying to tell me. But all I heard was you ought to eat more fiber. So I went home and I told Mary, I said, we're switching to brown bread. And that's what we did. And that continued for a few years. That was when Mary and I first met. That was in 1971. After we met, got married, we decided to leave Michigan. And we went to Hawaii. And that's where I learned basically everything I'm going to share with you this weekend that I know. And if you ever attend the 10-day program or any other interaction with me, you can remember that everything he knows, he learned 40 years ago. In 1973, after spending a year in my internship at Queens Medical Center in Honolulu, Hawaii, I took a job as a plantation doctor on the Big Island of Hawaii. And there I took care of 5,000 people, plantation workers. They were first, second, third, and fourth generation Filipinos, Japanese, Chinese, and Koreans. They'd done the same kind of work for 100 years on that plantation. The same genes that were the same genes that their relatives of 2 or 3 or 4 or 10 generations had. And yet what I observed during my short time at the plantation between 1973 and 1976 was a great difference in the health of these people. My first generation patients who were raised in the Philippines, Japan, China, Korea, who learned to diet of rice and vegetables, never had heart disease. They never had rheumatoid arthritis. They never had multiple sclerosis. And they never had hemorrhoids. They never had colon cancer. All the things that Dennis Burkett had told me were lacking in his patient population in Uganda, my first generation patients didn't have either. And what they shared in these populations was both populations lived primarily upon starch, corn or rice or potatoes, and had very little meat and dairy. The second generation, raised in Hawaii, they gave up some of their traditional diet. They started eating more of the good old American foods. And they got fatter, and they got sicker. And by the time I got to the third generation of my patients, they were just as fat and just as sick as everybody else. That was my first serious clue that diet was paramount. And that's when we started changing our diet in those times, between 1973 and 1976. And by the time I left in 1976 to return to get my internal medicine training, I eventually became a board-certified internist. By the time we left in 1976, Mary and I were pretty far along in our dietary change. And I was pretty dedicated to changing the way I was going to practice medicine. But I learned what every other internist learned. I learned how to do standard internal medicine, but my loyalty was no longer there. And then in 1977, something really paramount happened, and that was Senator George McGovern. Senator George McGovern, he was learning some of the same things that I was learning, and he put together the U.S. dietary goals in 1977. It was February 1977. Here, I'd just gotten excited about this, and anytime I heard of somebody else knowing the same things or similar things to what I knew, I got so excited, and I saw Senator McGovern and his committee sort through the similar information that said the rich Western diet was killing people. The meat and dairy industries were feeding foods that were sickening Americans. And they wrote the U.S. dietary goals in 1977. That was February. But by the end of 1977, the meat and dairy lobbyists had become involved in the bill and got the U.S. dietary goals completely changed. So industry beat government, but government tried. And then about 1979, I met this man, Nathan Pritikin. I have some mentors, and I love to talk about my mentors. I love to talk about the people who brought me to where I am today. Nathan Pritikin is a man who started the Pritikin Longevity Center, published almost 200 articles in the scientific literature showing the benefits of taking meat and dairy out of people's diets and instead feeding them common starches like rice, corn, potatoes, and so on. I felt like I was a lone person preaching this message until I met Nathan Pritikin. And then C. Everett Koop, he decided to replicate what another Surgeon General had done in 1964, which was to tell the public about the hazards of the way we live. In 1964, the Surgeon General came out and told us that smoking was dangerous. Now, back in 1964, about half the population smoked. And so the Surgeon General's report on smoking and health came out, in 1964. And what happened is people quit smoking. I mean, today, fewer than 20% of people smoke cigarettes. And so C. Everett Koop, his thinking was, well, we could address even a bigger problem, which is the food. And so he put together the Surgeon's Report on Nutrition and Health, which was published in 1988. And I thought, well, for sure, everything would be solved. 2 major government interventions. Experts talking about the importance of diet in terms of disease. It was all over as far as I was concerned. But no, the meat and dairy industry, they fought back. But government still tries to help the American public. They help them through the U.S. Department of Agriculture, which is kind of a schizophrenic department. The U.S. Department of Agriculture, they have loyalty to agribusiness. In other words, they want to make sure that the meat and the dairy and the other industries, they do well in this country. But they also have a loyalty to the American public. They publish documents such as the Dietary Guidelines for Americans, which come out every 5 years. And they try and tell Americans to eat less meat, less dairy, eat more vegetables, more grains, more fruits. But because of their mixed loyalty, they get a little confused, and the public does too. My point so far is to tell you that government has tried to intervene to help the public in all kinds of areas. There is purpose for government. I'm not here to talk about politics. The government is there to help us with things we can't do on our own, or individual companies can't do on their own, like defend us from foreign threats. But the government also should defend us from domestic threats. And unfortunately, the food industry is the greatest domestic threat that this world and this country has ever seen. Just few people realize it. So, in early 2011, I wrote SB 380. And in April, the Senate heard SB 380. And in September 6th, 2011, our governor, Governor Jerry Brown, signed into law SB 380, which requires physicians to learn about human nutrition. That was in September of 2011. And I thought, well, progress is being made. Unfortunately, the law handed the responsibility of making this work for the Californians. They handed it over to the California Medical Board. And it became their job to administer SB 380, the California Medical Board. And they delayed it. They had 3 years to deal with SB 380. They delayed it until July 17th of 2013 before they had their first meeting. Yes, they did. So finally they had the first meeting, and the first slide I showed at that meeting was the mission of the Medical Board of California. The mission is to protect healthcare consumers. That is their mission. And if you read the California Medical Board documents, you'll see that they have this mission of protecting the consumer. And it says right in their bylaws, it says, whenever protection of the public is inconsistent with other interests sought to be promoted, the protection of the public shall be paramount. I pointed that out to the California Medical Board. Well, SB 380, the law that I wrote that was passed and signed by the governor, it starts out by saying, existing law, the medical practice, provides for licensure and regulation of physicians and surgeons by the Medical Board of California. Under that act, the board is required. It's not maybe shall, this is you must. It is required to adopt and administer standards for continuing education of physicians and surgeons. That's what the Medical Board mission statement says. And specifically with SB 380 in the second section, this is just a short document, it's only a page. In the second section, it said, the board may also set standards for any educational activity concerning a chronic disease that includes appropriate information on the prevention of chronic disease and the treatment of patients with chronic disease by application of changes in nutrition and lifestyle behavior. Nutrition is mentioned 11 times in this one page. Diet is mentioned 3 times in the one page of SB 380. So the law is absolutely clear. The California Medical Board has the job of making sure the physicians in California know what human beings eat. There's no question about that. But they delayed it for 2 years until they had their first meeting. And by the way, I, about an hour and a half ago, talked to the chief of legislation of the California Medical Board. It was kind of like a bad relative with a big debt called her up. I mean, she had the big debt to the bad relative. But anyway, I talked about the progress of SB 380, and I'll try and remember to mention how things are going as the presentation comes along. So I thought SB 380 made a lot of sense. And Governor Jerry Brown must have too. I could see that this would result in healthier, less medicated Californians. Who wouldn't want that? And SB 380 would result in a more robust economy for the state of California. And that's what all the legislators are screaming about, is where do we get money for our schools, our police department? Where do we get money? Well, I'll show you where to get a big bucket full of money. Stop wasting it on unnecessary, harmful medical care is what I thought. Well, and more importantly, which many of you don't understand, but those of you who are doctors will understand, is more important is if we learned about nutrition, medical doctors did, we could be better doctors. We could help people. That would make us feel good. We went into this profession to be healers, to help people. Unfortunately, what we're given to help people doesn't work. But nutrition does, because that's the problem. That's why people are sick. Just like Dennis Burkett noticed, and just like I noticed on the plantation, just like Nathan Pritikin noticed, just like any of you, if you just open your eyes, you can see this. It's not a mystery as to why people are sick. It's not difficult to get them well. It's a simple change. So that's why I was excited about SB 380. That's why I thought the whole state of California would be excited, and why I thought the medical board would be excited, because their job is to protect the consumers of California. It says so right there. That's the first statement. Well, as far as the economy goes, you know, money talks. Believe me. If you go to the legislature, you talk to the people in the Senate, House of Representatives, anybody in government, they want to hear about the dollar. If it's going to cost anything, we don't want to do it, because we're just here to make the budget work. So healthcare costs. This is for the U.S. annually in 1980, $253 million. 2011, $2.7 trillion is what we're spending annually on healthcare. And that happens in California, too. In California, healthcare costs are $230 billion. This represents 12% of the gross domestic product California spent on sick people. All they want to know about is, how do you save money? How do you make the budget work? I thought this is a no-brainer. Everybody would be all over this. And a few people might be concerned about the fact that California, just like the rest of Americans, are sick. And that's not good. Obesity rates. More than 60% of adults are overweight in California. 24% are obese. And how about the kids? I mean, really, it's okay for adults. We can let the adults be sick. But how about kids? I mean, civilized people take care of their children, I think. But how do you justify 16% of the kids in California being overweight and another 17% being obese? And this is okay? This is how civilized people act? They allow this to happen? Diabetes. 8% of Californians have diabetes. But about a third of the population is pre-diabetic. They're ready to develop diabetes. And the costs, almost $8,000 per year per diabetic patient, that translates into $24 billion spent by California just treating diabetes. And heart disease, 6% of Californians have clinical heart disease. And the cost, an angioplasty is $82,000, bypass surgery is $100,000 for 5 years of care. That translates into $11 billion spent on angioplasty and $5 billion spent on bypass surgeries. Most are unnecessary, and all well-read physicians know this. But we're going to talk about this. So, diet and disease. For 30 years we've known this, that 5 of the 10 leading causes of death in our country are due to what we eat. Particularly cancer and heart disease and strokes, diabetes, other forms of atherosclerosis. A report just came out just a couple of weeks ago. The World Health Organization told us worldwide the leading cause of death is now ischemic heart disease, in other words, plugged coronary arteries. And the second leading cause of death is plugged head arteries, strokes, worldwide. This is a problem we're sharing with other countries. And Just less than 3 weeks ago, the Journal of the American Medical Association came out with a huge paper on the state of health in the United States between 1990 and 2010. And they looked at the various causes of disease in this country. And not for the first time ever, because the World Health Organization came out in 2002 and told us the same thing. But I think the clearest statement made came out 3 weeks ago. It was published in the Journal of the American Medical Association that told us it's the food, folks. It's the food that's making us sick. And the experts are starting to admit it. It's hard to admit, particularly since we received virtually no training in education during medical school, residency, or any part of our practice. It's hard for us to admit as doctors that there's something we don't know. But there is. We don't know what human beings eat or are supposed to eat. We hardly even knew that it mattered. I was told to eat a well-balanced diet, weren't you? Well, we know that the major cause of death and disability in this country is food, not tobacco, not auto accidents. It's the food. Obesity rates worldwide. If you see the countries with the high obesity rates, see they're the rich countries. United States, Canada, Western Europe, Australia. This is where obesity is common, and where it's rare, you already know this, right? Because you remember what people from Vietnam and Cambodia and Japan, you know what, they're not very overweight, are they? No, it's the food. Okay, so worldwide obesity rates, worldwide diabetes rates, almost exactly the same worldwide. And look at meat consumption worldwide. And dairy consumption worldwide. It's almost the same worldwide map I'm showing you, isn't it? Yeah. So it's well recognized without any controversy that the major cause of death and disability in the United States and the Western world is the food. World Health Organization said so. This large committee report just said so. It's the food. And what food is it? It's the rich food. It's the meat and dairy products. All right, I thought physicians should know that. And to prevent disease, what you do, this is the hard part, particularly for those of you who are new to this weekend. And you're hearing me for the first time, not even knowing me, not realizing whether or not I have any credibility or any particular personal biases to grind. You know, you're just sitting there thinking, how in the world can he say these things and be so confident about it and the solution be so simple? And then you start to focus on what I'm telling you. And for those of you who are new, you're thinking, my goodness, he's telling me I must give up meat and dairy. Well, that's paramount to starving to death. I don't know anything else but meat and dairy. There's nothing to eat. Well, what we're here to share with you this weekend and in the entire McDougall message is there is something to eat. It's the same food those people in Uganda still eat. The same foods that my plantation patients' relatives used to eat, and most of them still do eat. It's starch. It's rice, corn, beans, and potatoes. You know, instead of thinking when somebody tells you that you must give up meat and dairy, instead of thinking I'm going to starve to death, like if somebody told you you had to give up air, you think you're going to die from shortness of breath, or somebody told you to give up water, you're going to die of thirst. Instead of you thinking, well, he just told me I'm going to die of starvation, of hunger, you think, oh no, all he's asking me to do is replace pork chops for pasta and marinara sauce, beef for mushu vegetables and rice, chicken for bean burritos. That's all he's talking about. So that's the substitution that I learned up to this point, and I didn't when I wrote this bill, and when I testified in front of the Senate, and when I went to the board meeting, the California board meeting about 6 weeks ago, I never mentioned about the diet. I just said, you know, doctors should know what people eat. I didn't tell them that people ate a starch-based diet or shouldn't eat meat. I wasn't going to go that far. They would think that, you know, I had some particular agenda. I just said, and people have gotten upset with me, why didn't you write into the bill that people are supposed to give up meat and dairy? And instead, I couldn't. I would never gotten away with that. I just figured if we could shine a light on the subject, and people looked at the research and the evidence and were forced to look at it, that the truth would come out, and I still believe that. So, when I tell this story, the first thing you think about, and even those of you who have known me for a long time, but of course those of you who are new, the first thing you think about, he's saying, you know, I'm not supposed to eat meat and dairy, and instead I'm supposed to eat rice, corn, potatoes, beans, peas, lentils, fruits, and vegetables. But you know better, right? Because if you don't eat the foods that we all learn to eat, you're going to develop You're going to develop calcium deficiency. And when I say calcium, you say what? Okay, you say milk. Jeez. Okay, and then the next thing you say is, he just said protein. Protein. Oh, everybody knows protein. When I say protein, what do you think? Okay, meat. Okay, and then you know that you can't listen to what I'm saying because of something else we all know about that's really important. You have to get from your food, and that's omega-3 fats. So I say omega-3 fats. You know you have to eat fish. Okay, so you have to eat dairy, and you have to eat meat, and you have to eat fish, or you'll become a nutritional nightmare. Except for this one problem, and that problem is, if you study the scientific research, which I've spent 40 years studying, if you talk to any expert, any place, worldwide, you'll discover some interesting fact, and that is that there's no such thing as dietary calcium deficiency. No person who has ever walked this earth has ever developed dietary calcium deficiency on any natural diet ever fed to any person. There's probably been 10 billion people on this planet so far. And there is no such thing as protein deficiency. Nobody's ever developed it, ever, as long as you get an adequate number of calories. It's never happened. And omega-3 fats are made by plants, not by fish. So an entire philosophy is based upon 3 myths that would be easy to correct if anybody stopped and looked at the issues. Anybody read the research. But, you know, industry's powerful. They rule. All right. And that rule, of course, is driven by the same thing that drives everything in your business. That's money, right? Money drives everything. Money drives office visits, laboratory tests. Money drives hospital visits. We have a brand new hospital right down the street. Every time I pass that hospital, I say to Mary, it's not even open yet. I say to Mary, we're going to put that place out of business. That's our job. And in your town, you've got a new cancer center, you've got a new heart center, you've got a new hospital. Listen, this is not about conspiracy. Nobody's trying to hurt you or your family. This is just business, that's all. And so try and think about that as I talk, and maybe some of the other speakers, this is just business. It's just a matter of profit and loss, that's all. If it was a conspiracy, the people in the drug industry, the meat industry, the dairy industry, they would know this and they would protect themselves and their families. But that's not true. The women in these industries are getting breast cancer and obesity, and the men are getting heart disease and diabetes, and the children are fat and constipated. Their children. This is not a conspiracy. This is just business, that's all. Just business. Of course, the major business is the drug industry, gone from a very tiny, relatively tiny business in 1980, and I was already a practicing physician for 8 years, to a huge industry. The drug industry is pretty much the biggest industry in the United States. All right. People, how big is this industry? Half the population is on medication. If you go to a doctor's visit, that doctor's visit is going to end up in you getting a prescription 74% of the time. That's all doctors know. That's all they were taught. Why were they taught that? It's just economics. It's just business. That's all. All right. So what happens is this. Let me share this with you. I've shared this man's story many times, but it is a good representation of what the problem is. This is a guy I met a couple of years ago. One of the wealthier people in the Bay Area. He's an inventor. Has a home in Oakland, has a home on the Russian River. And the point being is that he's a very powerful, intelligent man, and he can get pretty much everything he wants because he has the money and the freedom to do it. And so he has a chance to see the best medical doctors in the Bay Area. And so this gentleman, 2 years before I met him, he had problems with high blood pressure, type 2 diabetes, hypercholesterolemia, hypertriglyceridemia, gout, bowel, kidney failure, overweight, osteoarthritis, constipated, and depressed. And he went to the best medical doctors in the Bay Area. These could be the best medical doctors at the National Institutes of Health, could be the best medical doctors at UC Davis, best medical doctors any place in the world he could go to. But he went to the doctors in the Bay Area, the best, at Stanford, UCLA, etc. After 2 years of intensive medical care, here's the picture of him when I met him. Okay, he's got high blood pressure, type 2 diabetes, hypercholesterolemia, What changed in 2 years? His shirt. Yeah, he changed his shirt. Yeah. The only other thing that changed is he's still a fat, sick guy. He's just carrying around a bag full of drugs. Now stop and think about this for a minute. I want you to really think hard. Do you know anybody that has received anything but this kind of care? Think of Aunt Millie and Cousin George and Emily at work, who have gone for the cure. They've gone to the doctor for sincere benefits of getting well and getting rid of their disease problems. And everybody you can think of, stop for a moment, everybody you can think of got this. They got a bag full of drugs. And so they're just a bunch of fat, sick people carrying around a bag full of drugs. That's it, no exceptions. And what I explained to the California Medical Board is this isn't right. We owe the citizens of California much, much more, because we know better. And I did mention the California Medical Board does fail to protect the consumers. Maybe that's why they're not looking forward to our next meeting. I don't know. I did point out that the California, when it comes to diabetes, let me just take a couple examples here. You need to know that diabetic medications, that means insulin or diabetic pills, they're approved based upon their ability to lower blood sugar, not upon their ability to make the patient healthier. Only upon their ability to lower blood sugar. That's how they're approved. Now, various organizations have said we should do better. We should be concerned about health, not just lower blood sugar numbers. Since 1972, there has been a warning in the physician's desk reference about the most popular diabetic pills, which are called sulfonylureas. And these diabetic pills, which are what most diabetics took in the past, and a good share of them are on right now, are sulfonylureas. Since 1972, it's been published in the physician's desk reference that these medications, compared to diet alone, will increase the risk of dying of heart disease by 2.5 times. And there's no dissension on this research. One of the first major studies published in 1996 was the Veterans Administration study, and what they concluded is they found a strong tendency towards worsening of cardiovascular outcomes in patients with intensive diabetic control. In other words, those who were asked to keep their blood sugars most normal had more heart disease. There are 6 major studies. I'm going to show you them all. I'm not cherry picking. There's not some other major study sitting out on the sidelines that tells you differently. The TRACE study, big European study, the biggest study ever done, TRACE study. Diabetic patients treated, this is Europe, treated with oral hypoglycemic agents or insulin, but not those treated with diet alone, have a significantly increased mortality following myocardial infarction compared to non-diabetic patients. Now, those were the older studies done. There were 3 major studies done prior to 2008. In 2008, the New England Journal of Medicine carried 3 articles. 3 major studies, the results of 3 major studies. These, as far as I know, are the last studies that will ever be done on treating diabetics with medication on this grand of a scale. What they did is they took diabetics, very large numbers of diabetics, and they divided them into 2 groups. One group, they said, we'll just give you usual care. You can see the doctor once in a while, just take care of your blood sugar here and there. And then the other group will treat like everybody believes a diabetic should be treated, and that is to try and make their blood sugars as normal as possible. And as normal as possible is based on a long-term blood sugar test called a hemoglobin A1C. And a normal hemoglobin A1C is 6% or less. So they took this large group of people, divided them into 2 groups, and one group they just kind of let them go on with their usual care. Their hemoglobin A1Cs ended up around 8%. The intensively treated group, which often got 4 shots of insulin a day, took 3 or 4 different diabetic pills, checked their blood sugar 3 or 4 times a day. Intensively treated group, they got their hemoglobin A1Cs down to close to normal, close to 6%. But the problem is, and this was the first study published. This was published in, well, actually, it was probably a little later in 2008, but it was February 2008 when the National Heart, Lung, and Blood Institute came out, 17 months early, before the study was supposed to be over. And they said, the study is done. We cannot continue the study because of the dramatic increase in death and heart disease among those who were intensively treated. That was called the ACCORD study. And then, a few months later, the ADVANCE study came out. And the ADVANCE study showed no benefit when it comes to cardiovascular disease or death. Hypoglycemia was much more common, low blood sugar reactions, where the sugar gets so low that sometimes people get picked up for DUIs, fall down, hurt themselves. very low blood sugar levels, no benefits at all in these people in the advanced study. Then the veteran study came along and they showed increased risk of sudden death. They showed in the intensively treated group they gained 18 pounds on average as opposed to the control group, which gained 9 pounds on average. So there was a much greater weight gain. They showed no benefits in eye changes, kidney changes, the other things that are often sold to doctors and patients as the reasons that they should treat their diabetics aggressively. So the major studies all show the same thing, and that is an increased risk in death, weight gain, sudden death, heart disease, in people who are aggressively treated. So I told the California Medical Board, why do you keep letting the state of California pay for things that are hurting our citizens? I did mention that. So, yeah, it lowers blood sugar, but the results of the cumulative studies, you will not find dissenting reports here. It's not like there's somebody out there with a whole bunch of other research that says otherwise. You have higher mortality, more heart disease, increase in sudden death, more hypoglycemia, and twice the weight gain. The California Medical Board's job is to protect the citizens, the consumers of California. How does that fit in? So, the California Medical Board, I did point out, could do something for diabetics. They could help them. Back in 1927, Joslin, the famous Joslin Clinic, Joslin knew that diabetes and also the resulting poor outcomes with increased risk of death and disability was related to the diet people ate. And what he said back in 1927, he said, I believe the chief cause of premature atherosclerosis and diabetes, say for advancing age, is excess fat. An excess of fat in the body, an excess of fat in the diet, and an excess of fat in the blood. With an excess of fat, diabetes begins, and from an excess of fat, diabetics die, formerly from coma and recently from atherosclerosis. Let's see, 1927, that's as long, 86 years ago. We knew from experiences in Western Europe during the wars, when people had to give up the meat and dairy. It wasn't available because of rationing in Western Europe. People were forced to change their diet. We saw a dramatic change in the incidence of disease in these times of tremendous stress. People were shooting at citizens and gassing them and incarcerating them and separating families, terrible stress. And yet, what they observed is the following in terms of diabetic deaths in England and Wales, and this is the rest of Western Europe too, is that prior to World War I, the death rate from diabetes was increasing. And then World War I came along, and in Western Europe, people couldn't afford to eat rich foods anymore, and the death rate from diabetes dramatically decreased. Post-World War I, good times returned. Death rate from diabetes dramatically increased. During the war years, the death rate from diabetes dramatically decreased. And this is in all Western European countries. This isn't just diabetes. This was heart disease and multiple sclerosis and obesity and other common problems. We know these things can be stopped, and this evidence here tells us that they can be reversed. All right, some of our earlier treatments of type 2 diabetes. This guy always sticks in my mind, Rabinovich. Published in the early 1930s. He was from Canada. He went around the United States and Canada and taught people about treating type 2 diabetes with a high carbohydrate, which means lots of starches, vegetables, and fruits, and a low-fat diet. He published his results in the Canadian Medical Association Journal. And he said something. He said, may I, however, observe that we now have over 500 patients on this diet, and that there were 16 failures among them. At least in my opinion, a highly satisfactory state of affairs. That's 1932 that was published. And Hemsworth is one of the most famous doctors in diabetic research. In 1940, he told us how this works, how when you eat fat, it paralyzes insulin activity. He took diabetics and he put them on high-fat or high-carbohydrate, low-fat diets, and he showed that their diabetes got better. And this was, actually his work started in 1927. But was published in the British Medical Journal in 1940. He showed us what causes type 2 diabetes. It's the fat, just as Joslin had said. And when you put people on a low-fat diet, they get better. And Nathan Pritikin, who I mentioned, was one of my most important mentors. He published research in the scientific journals that showed that diabetics got off their medication and their blood sugars dramatically improved. And James Anderson, University of Kentucky, he published his work in the 70s and 80s. And showed type 2 diabetics, you could basically cure them. 11 of the 20 lean, these are lean people, discontinued insulin. And that was all published in the scientific literature, but it lacked one important thing, and that was a financial incentive to spread the message. Neil Bernard just recently published his work on type 2 diabetes, showing the same thing. You take the meat, the oil, the dairy out of somebody's diet, but what do you have to feed them so they don't starve to death? You have to feed them pasta and lasagna and bean burritos and veggie. So I guess the things we're having this weekend, that's what you have to feed them. Walter Kempner, again, one of my heroes. He was at Duke University, came there in 1934, really made a big impact by 1939, published all of his research by 1953, showing that the rice diet, a diet of rice and fruits, and later on he got some vegetables, a diet like that would cure people with heart disease and kidney failure and high blood pressure. And even diabetic retinopathy, which no patient with diabetes that I've ever met in this country or anyplace else has ever been given the advantage of when their eyes go bad from diabetes. Walter Kempner showed in his publications, he wasn't the only one either, a guy named Van Eck did it too and published it, showing that if you take diabetics who have damaged their eyes and you put them on a healthy diet, what happens is the exudates and hemorrhages disappear. These people, all this bleeding and all these exudates, the white material in here, virtually goes away by a simple dietary change. I thought doctors in California should know that. That's what I told the medical board. Well, we have had some information about type 2 diabetes and dietary issues lately. For example, we've learned about type 2 diabetes and obesity. They're kind of equal. With type 2 diabetes, not type 1 where your pancreas doesn't make enough insulin, but type 2 where your pancreas makes all the insulin you'd ever need. In fact, often makes twice as much insulin as somebody without diabetes. We know that that's due to insulin resistance caused by people becoming overweight. So our type 2 diabetics are almost always overweight. And when they lose the weight, they get well. This was so exciting. This was spring of a year and a half ago. Published in the New England Journal of Medicine, back to back, 2 articles where they caused people to lose weight, not under their own control. They actually did bariatric surgery on them and put various types of restrictions on their stomachs so they couldn't eat. And as a consequence of this obesity surgery, which is very popular these days, not only did these people lose weight, but they cured nearly 80% of the type 2 diabetics just by weight loss. But getting weight loss by the proper means of making a diet really didn't come into anybody's mind. It still doesn't these days. I was just talking to Don Forrester just a minute ago about how Kaiser Permanente pays a tremendous amount of money for its patients to lose weight, cure the type 2 diabetes by surgical means. This is one of the more common practices these days. You would think that any means of losing weight would be worthwhile. After all, you can do it by surgically creating malabsorption in people. As a result, you cure the type 2 diabetes. This is a real big plus for bariatric surgeons, right? I mean, this is a growing business for these doctors who cure obesity with surgery. But we don't have to limit this newfound therapy to just bariatric surgeons. I think the rest of the medical business ought to get in on the obesity business, don't you think? 80% of the people are overweight. Medical doctors could enhance their practices greatly. Not just doctors, but also dentists. Do you remember, I was talking to Mary yesterday, do you remember the days when the treatment for obesity was wiring your teeth together? Do you remember that? I mean, those of you who are younger can't believe that was a treatment. That was a common treatment. So dentists can get into the diabetes cure business. Dentists can. And we could cure diabetes. Neurosurgeons could cure diabetes. They could just go in and do frontal lobotomies and take the cure type 2 diabetes in obese people. That would work. And how about oncologists? Oh, they have so many drugs that cause weight loss, these oncologists do. My goodness, you can cure high cholesterol and type 2 diabetes by chemotherapy. We can get the chemotherapists involved in the weight loss business. Or how about the general surgeons? We don't want to leave the general surgeons out. General surgeons could do bilateral lower extremity amputations so the diabetics couldn't get to the refrigerator. And we could cure type 2 diabetes. We could do that. Or we could teach people in California responsible medicine, like changing their diet. These are results that we're in the process of publishing now. This is on nearly 2,000 of our people, 1,700. And this is weight loss in 7 days of force feeding, the foods that you guys are going to eat this weekend. The average weight loss in women is 3.1 pounds, eating as much as they possibly can of the foods that we're sharing with you. Men, 3.6 pounds, 7 days. And we have long-term weight losses that you're going to hear about later on in the weekend. So it was pointed out in 1987 in diabetic management, it's important to remember that diabetic control means a lot more than just blood sugar control. All right. California Medical Board, I told them, I said, you know, you're failing to protect the consumers of California because of heart disease. Now, 6% of the population has heart disease. This has cost the state of California billions of dollars. And the most common manifestation of atherosclerosis is a heart attack. 1.25 million people in the U.S. have heart attacks every year. Half those people die of their heart disease, and it's not just the heart arteries that get plugged up. The arteries to the eye get plugged up, you get macular degeneration, you lose your hearing, you have strokes, heart attacks, aneurysms, kidney failure, viral infarcts, degenerative disc disease, claudication, gangrene, impotence, etc., all due to low blood supply to various tissues. This is a big deal. And the way you have a heart attack, I just want to address this for a minute. The way you have a heart attack is very important to understand what's going on here so I can explain to you why the current treatments for heart disease fail, and they have to fail. It's because a heart attack is not due to blockage of the arteries that occurs long-term. You know, it's not due to long-term blockage. What happens is the inside of the artery gets damaged, and as a consequence of the damage, you get a sore. The damage is caused by food, primarily food. Cigarette smoking contributes. But as a result, you get sores on the inside of the arteries. These festering sores, they get bigger and hotter, more volatile. And then what happens is a tiny sore, you can see it under a magnifying glass, it bursts and a blood clot forms, and that's how you get a heart attack, is when the sudden blood clot forms. We call it a coronary artery thrombosis. Now, it's important you understand that's how you get a heart attack. A heart attack is not from gradual closure of your arteries with these fibrous, hard plaques. It's from a sudden rupture of a plaque. It's almost every heart attack and almost all strokes occur as a consequence of that mechanism. Well, what surgeons operated on, either with angioplasty or bypass surgeries, they operate on old disease, old fibrous disease. One of these plaques ruptures, you get a fresh blood clot over the sore. Over a matter of days to weeks, that fresh blood clot is infiltrated with white blood cells, fibroblasts, comes in and replaces the blood clot with scar tissue. So you got a little bit of scar on the inside of the arteries, and you get another little plaque rupture. A few months later, you get another blood clot over the top of that scar. It organizes with fibrous tissue into scar tissue. Now you got a 2-layer scar. And as time goes on, what happens is these scars build up. And when a surgeon gets busily involved in your care and looks into your heart arteries, what they do is they see these scars. This is an angiogram. Catheter going to the heart. These are the heart arteries. And you see these scars. These are old, fibrous, stable, non-lethal plaques. Everybody knows this. What kills are the little tiny pimples that you can hardly see that pop and form a sudden blood clot. Heart surgery operates on the old scars. It doesn't operate on the killing part of the disease. And so as a consequence, what we see multiple studies. There have been 28 studies done the last time I reviewed it. They all show the same thing. These are two of the most important ones. This is the OAT study. The OAT study is a study of 2,200 people who had a heart attack, and 3 to 28 days later, what they did is they did catheterization. So in other words, they had a heart attack, they had this fresh clot form, which, by the way, you want to get treated. If you have a heart attack and a fresh clot forms, if you can get to the operating room within 90 minutes, the cardiologist can go in with a catheter and squirt blood clot dissolving medicine on that clot, dissolve it, and save heart tissue and probably save lives. But after 90 minutes, then what lies distal to that blockage is dead. And the clot gets well organized, so this kind of treatment doesn't work. And so they proved this in this particular study, one of the most important studies done, the OAT study. They proved this when they looked at these patients that had had a heart attack. 3 to 28 days later, they looked into their heart arteries, and they did angioplasty, where they opened the artery up and usually put a stent in there, a metal propping device in there. And they looked to see what happened. They expected great results because they opened the artery. But that's not what they found. What they found is that angioplasty did not reduce the occurrence of death, reinfarction, or heart failure. In fact, there was a tendency, if you got the angioplasty, to have a worse outcome at 4 years. This is the OAT study. This was disturbing, to say the least. And then they did the COURAGE study, which was really the final nail in the coffin. The COURAGE study, 2,300 people who had evidence of serious artery disease, they either did angioplasty on them or they didn't, and the outcome was no benefit from doing the angioplasty. Well, the American Heart Association, the American College of Cardiology, which are respected experts in the field of cardiology, they reviewed the 28 different studies, particularly the OAT and the COURAGE study, and they came to the conclusion that something was wrong. And in 2007, what the American Heart Association, the American College of Cardiology did is they told physicians in the United States, cardiologists, to stop doing this. Stop doing heart surgery on people with old scars. In other words, anybody past 6 hours, so they have a heart attack. It's too late. Stop doing heart surgery on these people. And what do you think happened? Well, it was actually studied to see what happened to cardiologists' behavior. It was studied, it was published in the Archives of Internal Medicine in 2011. It's the study, the title of the study is quite revealing. It asked the question, what is the impact? Was the impact of national clinical guideline recommendations? That's the American Heart Association, the American College of Cardiology. What was the impact of these two major organizations on telling physicians who are doing angioplasty on persistently occluded, in other words, old coronary artery disease, what is the effect on clinical practice in the United States from these major guidelines? Is what they asked and what they published in July of 2011 in the Archives of Internal Medicine. There was no change in adjusted rate of angioplasties for total occlusion identified at least 24 hours after the heart attack, following publication of the OAT study and revision of the major guidelines. In other words, doctors didn't do anything. There was no change in behavior. The results of the study are cause for concern at two levels. First, they imply that many stable patients with recent heart attacks and persistent occlusions continue to undergo costly and ineffective procedures. And second, a large public scientific and human patient investment in the generation of robust guidelines. In other words, for the American Heart Association, the American College of Cardiology to gather all this evidence, come to some recommendations to help protect people, including Californians, was completely ignored. Yeah. I told the California Medical Board they should be concerned about it because they're paying for this. And we're talking about billions of dollars. And you're talking about budgets. On an editorial that accompanied this, they said, this article said, in addition, in a fee-for-service health system and in an environment in which more and more physicians are being compensated on the basis of relative value unit productivity, it remains to be determined whether personal financial, in other words, there you figure it out. Personal financial gain might play a role in continuing old practices and performing procedures that show no benefit. I told the American Heart Association or the California Medical Board they were paying for this. But you could do different. I told you could do different. We know what causes heart disease. There's the cholesterol hypothesis, which identifies eggs, dairy, and meat as the cause of rotten arteries. And there's the new hypothesis, which is just came out in the New England Journal of Medicine this year, which says the mechanism is a little bit different. It involves the production of trimethylamine oxide in the gut of people who eat meat. Only meat eaters can do this. Produce trimethylamine oxide, which is toxic to the arteries. And so as a consequence of consuming meat, dairy, and eggs, you see, they're saying the same thing, just a different mechanism. You get rotten arteries, you get atherosclerosis. Well, I told the medical board they could do different. We know what the cause of rotten arteries is. We know that the treatments that we're doing fail. We could look at Nathan Pritikin's work, which, well, he's a case example himself. He had severe coronary artery disease in February of 1958 when he got interested in dietary change and treatment. And his cholesterol at that time was close to 300. He changed his diet and dropped his cholesterol to about 100. And his last statement to the world was his autopsy. When the man was autopsied at nearly 70 years of age, they said several systemic arteries showed a little bit of flat streaks, no infarcts, no serious reduction in the anatomy. This is a man who was 40 years old who could barely walk on a treadmill. And they said in a man 69 years old, the near absence of atherosclerosis and the complete absence of his effects are remarkable. And they published that in the New England Journal of Medicine. And then Caldwell Esselstyn, our good friend who's appeared here many times, has a large series of patients who have shown reversal of atherosclerosis. And of course, you know this guy, he's a frequent guest on this stage, Dr. Dean Ornish. It was published in the major medical journals that you stop or reverse the disease 99% of the time. And the major therapy involved is diet change. So the California Medical Board can help to protect consumers. They can do that, I said. But the way you have to do it is you have to start with the providers, the doctor. You're going to do whatever the doctor tells you to do. So the doctors have to know about nutrition, and they don't know anything about nutrition. Nutrition education today, as it was 40 years ago, my son just finished his training. He will tell you. And those of you who are young doctors and old doctors will tell you, nutrition education means memorizing biochemical formulas. It has nothing to do with diet therapy. It's a matter of looking at cellular metabolism. It has nothing to do with about patients. Nothing. And that amounts to somewhere between 1 and 10 hours of education over 4 years. It has nothing to do with patient care. Nothing to do with what I just showed you. More than half the students surveyed said they don't get enough nutrition education. The American Medical Association realizes that we're not teaching our students about nutrition education. I proposed in SB 380 that we make doctors learn about nutrition. What I originally proposed was that doctors would be required to take between 8 and 14 hours of continuing medical education credit to get licensed initially and to get relicensed after that. You'd have to take a course on nutrition, whether it was about Atkins or McDougall or Ornish or what. You had to take a course on human nutrition. You must know something about what people eat. And you'll be forced to get your license renewed. You'll be forced to take a class and prove that you got this continuing education. This is not an unusual thing to do. California requires 12 hours for pain management and afterlife care. All these states here require doctors who are deficient in a certain area of patient care to get continuing medical education so that they can make up for that deficit. This is usual behavior in terms of government inaction with medical practice. They made me take this slide out when I presented this lecture to the California Medical Board. I had to put it back in. After my conversation this afternoon, I had to put it back in. You see, the California Medical Board, like all medical boards, they're known for discipline. They discipline doctors who are inappropriate in terms of drug use, alcohol use, patient behavior. They come out and they act like the bad cop. And so in their particular mission, if you read their mission, they talk about 8 different points. And the bad cop part, which is the practice of the California Medical Board and the other medical boards across the country, this is usual behavior, is enforcement of disciplinary and criminal provisions of the Medical Practice Act, taking care of bad doctors who have drug problems, administration and hearing of disciplinary actions, that's the bad cop action, carrying out disciplinary actions appropriate to findings made by a panel or administrative law judge, suspending or revoking, otherwise limiting certificates of doctors who practice. This is good. But is this all the California Medical Board and other medical boards should be doing for its citizens? I don't think so. They could. They made me take this slide out too. They could be good cops. And the next 4 provisions in their mission statement are what I would like them to do. It's already there in the law. In their mission statement. This is not new. Reviewing the quality of medical practice carried out by physicians and surgeons. Approving undergraduate and graduate medical education programs. Don't you think doctors should be required in medical school to learn what human beings eat? It says right there they have that responsibility. Approving clinical clerkships, special programs and hospital programs. Administering the board's continuing medical education program. I asked that they force physicians to learn what people eat. That's what I asked. All right. So what I suggested were the following things that are July 17th, 2013, California Medical Board, first meeting after 2 years after the law was passed. They were allowed 3, by the way. And they told me just how wonderful they were that they did it in 2 instead of 3. I said that you could require continuing medical education for newly licensed and relicensed physicians, just as I explained. You could require the 11 medical schools in California to hold a single meaningful course on diet therapy. The California Medical Board could do that, but not a single medical school in this country, much less the 11 in California, have a course, an hour, a minute dedicated to diet therapy. Now or 40 years ago. They do not. They could. They could. You know, during this meeting I had July 17th, it was kind of interesting. I have this way of things go from my head to my mouth. They said, well, we will handle this SB 380, which, by the way, is not the way SB 380 is going to be handled. But they said, we'll just put a little paragraph in our California Medical Board newsletter every month or two, a few months. I said, excuse me. I said, why don't you go for the throat? Why don't you go to the medical schools and ask them why they don't teach the students about human nutrition so they can be effective young doctors? Why don't you do that? I asked him. Anyway, I said you could require the 393 general hospitals in California to dedicate some of their noontime conferences to diet therapy. None of them do now. The only education I had on diet therapy was in 1971 when I was a senior medical school from Dr. Dennis Borkert. Yeah, I said we could do that. We could audit medical practices, which they do now too, and they could see whether or not they're using inappropriate care like aggressive diabetic pill and insulin therapy versus dietary therapy. They could see if doctors are doing that and penalize them for not acting properly to protect the consumers. They could do that. See whether or not they're sending them off to meaningless and harmful heart surgeries. They could do that. They have the power to do that, I do think. I know they do. Well, that's what I suggest the California Medical Board do. And then, of course, they could send out a paragraph in the newsletter every month or two, which is what they're planning on doing. That's all they're going to do. Anyway, so I went to Hawaii. And Mike Gabbard, senator in the 19th District of Hawaii, last year he proposed legislation called SB 608, which is basically SB 380, and asked the state of Hawaii to do the same thing, to require their physicians. Mike Gabbard wrote a letter a couple of weeks ago to the John Burns School of Medicine, asked them, why don't you teach the medical students anything about human nutrition? I think that's a fair question. State by state, we're going to change the way medicine is practiced. It may take a while, and it may take laws, and you might not like that. You might not think that's fair. You may not want the government involved. You may think that I'm being mean to physicians. But I never took an oath to protect the financial interests of doctors. But I did take an oath to protect the financial interests of my patients, and so did the California Medical Board. Their mission is to protect healthcare consumers, and they are not doing it. And as far as I can tell, they will continue to avoid the subject with as much effort as possible. I plan differently.